been really excited about presenting this work to you, and without further ado, I'm going to let Dr. Baird take over.
Okay, bonjour tout le monde, good morning. None of us have any disclosures. Pediatric appendicitis is and probably always will be the most common pediatric surgical emergency. In North America and worldwide, pediatric appendicitis is more commonly treated at non-pediatric centers. We know this. Over 1/3 of patients undergo a CT scan as part of their diagnostic workup, either up front or as secondary imaging. And we know now that ionizing radiation has been definitively linked to the development of cancer. The younger the patient, the greater the risk. The purpose, therefore, of our work was to create consensus, evidence-based guideline recommendations for the diagnostic pathway of pediatric patients presenting with suspected appendicitis. This work is meant to encompass and be applicable to a variety of clinical care contexts, including your health networks. Our methods were rigorous. We engaged a diverse set of stakeholders and held prioritization meetings. We conducted a coordinated search and included all recent relevant literature. We performed critical appraisal and data abstraction, generating levels of evidence, and ultimately a set of recommendations based on grade methodology. To enable the work, we queried 3 distinct phases along a patient's care trajectory. First, we evaluated evidence concerning decision-making prior to any diagnostic imaging, primarily focusing on scoring systems. Then the specifics of primary imaging modalities, that is ultrasound, CT, and MR. And finally, decision-making that ensues after the primary imaging has been resulted. This is our PRISMA diagram. We screened and evaluated several thousand papers, ultimately including well over 100 relevant works. And I'm pleased now to invite Sophia to come on up and tell us a little more about it.
Our data suggests that scoring systems help better assign risk for patients with suspected appendicitis. Although there are many commonly used scoring systems out there, including single-center algorithms, the most commonly used are Pediatric Appendicitis Scoring System, Alvarado, Appendicitis Inflammatory Response, Pediatric Appendicitis Risk Calculator, and Repasa. Some are based on objective data alone, while others are confounded by more subjective reports coming from parents and guardians. The key to this is consistency. Our data does not directly show that one particular scoring system overrules in terms of diagnostic accuracy, but that there is consistency within the center or region. Some of the key studies are outlined here. We strongly recommend that all pediatric patients with suspected appendicitis are evaluated using a validated scoring system, such as the ones limited below. Patients identified as low risk do not require additional workup or imaging, though with intermediate risk, we do suggest further evaluation that will be outlined in the following slides. For patients as high risk, we do show that they need direct surgical consultation, and in a faculty without pediatric surgical services, consideration may be given to be moved to another center without imaging.
Press the green button. Is that right? Green button. Perfect. Thanks. I was just checking to make sure I pressed the correct button. Perfect. And so for my job, it was to look at the primary imaging. So what imaging is done first, right? And we'll talk a little bit later on with some recommendations of what happens after this. But typically we have 3 types of modalities for imaging. We'll look at ultrasound, we'll look at CAT scan, and MRI. And as we all know, as pediatric surgeons, ultrasound tends to be the imaging modality of choice. It's obvious, there's no radiation. With that, it is universally available. It is easy to even get it right at the bedside, so you can do point-of-care ultrasounds. So it's universally approached by our emergency room physicians, by our radiologists, by many people. But the sensitivity and specificity are a little lower than when we look at cross-sectional imaging, and there's multiple reasons for that, we think. Some of that is due to patient body habitus, bowel gas, difficulty with the interpretation because of the patient characteristics, but also some user specifics as well. We notice that in high volume places, ultrasound for appendicitis tends to be a little more sensitive, tends to be a little more specific because they are doing more of the ultrasounds. And so how do we combat that? From a research standpoint, people have looked at that, and so you can do more, but in some of the lower critical access hospitals, that may be difficult to have them do more volume, although they can practice and try to get more opportunities to see that. But they've also found that performance can be improved by using a standardized reporting system. So if you have a standardized template that the sonographer is looking at, as well as a standardized template for the reporting by the radiologist, that can improve the sensitivity and specificity. But sometimes this still doesn't work, and we do need to look at cross-sectional imaging. And the one that we always tend to talk about would be CAT scan, which obviously the downside from that standpoint, even with the higher sensitivity and specificity, is the radiation risk. So there's clearly not a zero risk of radiation. The impact of that continues to be reported in the literature as we look at blood dyscrasias or other malignancies. It is very rapid. We as surgeons tend to be able to interpret that very easily. It only really requires IV contrast, and for some of us older surgeons like myself, I remember we were given triple contrast and trying to do a lot of different contrasts. We don't need to do that anymore. You just need IV contrast, and you can get that answer relatively rapidly. But how do we avoid this radiation risk with cross-sectional imaging? And so the next modality you can look at would be MRI. An MRI can be actually performed without contrast. You don't need an IV. You can do it relatively rapidly. You don't need sedation because of that quick phase. The sensitivity and specificity are well into the 90s from that standpoint, but we have variable access for that. At my institution, we can actually get it relatively quickly, but not at many institutions can you do that, and it can take some time. And to be honest, there's terms T1, T2, TE, TR that we don't always recognize or use in our speech, and which modality do we need to look at, which one is fat suppression, which one is not. And so it can be very difficult to interpret from our standpoint. But through those literature reviews, we were able to find some recommendations, sorry about that. For patients with moderate high suspicion for appendicitis, ultrasound is the preferred initial imaging of choice. You should use an objective or a standardized template. And in younger patients, you should consider using an ultrasound and clinical risk scores for that. For the CAT scan, it can be an alternative for the imaging modality, depending on your available resources, and it should only be performed with IV contrast. You shouldn't need to give it oral contrast. And people can consider MRI as an alternative first-line imaging modality, depending on their available resources. And you can do that without an IV, without contrast, and without sedation. And I'll hand it back to Dr. Baird.
Okay, so what happens when the imaging is equivocal? Well, we have broken that problem into several different questions. The first is regarding re-imaging and optimization of initial imaging. We found, based on the evidence available, that overnight trainee ultrasounds are generally, unsurprisingly, inferior to daytime or those performed by faculty. Further, and interestingly, most CTs deemed equivocal for appendicitis at a community or regional hospital can be interpretable by pediatric radiologists. With regards to observation and transfer has not been shown to worsen perforation rates, and low and moderate risk patients with equivocal imaging can be reasonably observed. With regards to cross-sectional imaging, neither ultrasound nor CT confer benefit after initial CT. And finally, MR is attractive as a secondary imaging modality where feasible. And then, finally, unsurprisingly, a diagnostic algorithm for pediatric appendicitis reduces ionizing radiation without compromising either time or accuracy. Formally, the recommendations are as follows. When initial imaging results are equivocal, a secondary interpretation by a subspecialty pediatric radiologist is recommended. Repeating ultrasonography in improved conditions should be considered were it not causing significant delays in care. For patients identified as high risk by a validated scoring system, direct surgical consultation is appropriate. In a facility without pediatric surgical services, consideration may be given to transfer without imaging. If the initial imaging is inconclusive, transfer to a pediatric center should be considered over pursuing further imaging in non-pediatric contexts. For patients with a low or intermediate clinical probability of appendicitis and equivocal imaging, a period of observation or scheduled reevaluation in a reasonable time frame is considered a reasonable alternative to immediate secondary further imaging. With regard to cross-sectional imaging, CT or MR can be considered after inconclusive ultrasonography, especially if clinical suspicion persists. Repeat cross-sectional imaging, MR or CT, is strongly discouraged. MR is preferable to CT to minimize radiation exposure where feasible. and ultrasonography after equivocal cross-sectional imaging should be avoided unless there is a significant change in clinical circumstances. Cross-sectional imaging may be preferred in patients with an elevated risk of an alternative diagnosis. And finally, pediatric patients with suspected appendicitis should be evaluated within the context of a diagnostic algorithm. And so, the upshot of it all is this algorithm. It's available to you, and we'd appreciate your ability to socialize this across your networks. And I will show you this QR code again in a moment, but I'd like to walk you through this algorithm real quick. Every child with possible appendicitis should be initially evaluated with a clinical scoring system. Low-risk and high-risk patients do not necessarily require imaging. You heard that correctly. You have our permission to discharge or operate on a patient without a picture. Ultrasonography is preferred as an initial imaging modality, although cross-sectional imaging remains an acceptable option depending on patient and contact factors. In addition, transfer to a pediatric center within network should be considered either before or after imaging, depending on available resources. When that initial imaging is deemed equivocal, it is important to ensure it has been optimally performed and optimally interpreted. This may involve outside consultation with a pediatric radiologist. In circumstances where clinical suspicion remains, a period of observation is a viable diagnostic strategy. Otherwise, repeated optimized ultrasound or cross-sectional imaging should ensue. While this algorithm will not be universally accurate or necessarily supplant how you work at your quaternary care center, it is the hope of our working group that it serves to arm you all, pediatric surgeons, to work within your care networks to ensure that all children be evaluated in an evidence-based manner that optimizes diagnostic accuracy, timeliness, and reduces exposure to ionizing radiation. There's that algorithm again, and I'd be pleased to welcome members of the Quality Committee to provide you specific examples of successful radiation stewardship.
Good morning. My name is Nellie, and I'm here with Derek Wakeman from the Quality and Safety Committee. And today we're going to review the available projects that are already out there related to radiation stewardship of pediatric patients with suspected acute appendicitis. This really is meant to showcase the toolkit and share what has been set up in a variety of clinical care contexts with the hope that it can provide anyone here with a launching off point if you're interested in establishing these best care practices. So here is a screenshot of the APSA Quality and Safety Toolkit itself, which should be available if you just type into Google APSA Quality and Safety Toolkit. We do have a little QR code available, and it will be available again. But when you open that link, you essentially you get to this toolkit here that Dr. Wakeman's going through. And so before I get into it, I just want to make a little plug about the Quality and Safety Toolkit because not only are there available projects about appendicitis, but a variety of topics where there's established practices out there that can serve as a launching off point. So we can access this information in a couple of ways. One is through the appendicitis folder itself, and the other is through the radiation stewardship toolkit itself.
Can you guys transition to the online portion?
These are the slides again.
Doesn't seem to be working from here. That's okay. We can use the screenshots.
Okay, we did have a backup. All right, so they're seeing that, not this, right?
Can you just go back to the slides now? Please.
It's there, okay. All right, so again, QR code is available. There's a couple of different ways to access the content that is related to radiation reduction in pediatric appendicitis. One of those ways is through the appendicitis folder. So if you're looking at the screen, there's a couple boxes with a variety of topics. Appendicitis could be one of those, or radiation stewardship could be another way that you can do that. This is going backwards. Okay, so if you were to click through the appendicitis folder, you'll see that there is a folder called Decreasing CT Use, and so that's where we have really all of the content from the variety of institutions that have shared that content with us. This right here, again, is another way to actually view the content. The toolkit itself has been curated into the pediatric surgery library. And again, the link is here, and it's just a different format to the same content. So a lot of variety and easy access to this information. So what do we have out there right now? This here is a nice little summary of the institutions the 5 institutions that have shared their content with us. And what you can see is that they have provided a variety of different strategies as to how to help reduce CT utilization. So in general, what we found was that there are 3 general strategies that were employed. One is to improve ultrasound use via the establishment of clinical practice guidelines. Another is to improve the diagnostic accuracy of these ultrasounds with ultrasonographer education and templating that standardizes the reporting system. And then the third is improving the access to MRI so that you can use that rather than CAT scan. So fortunately, our toolkit does offer content for all of these. I will not go through the details of the topics themselves or the projects themselves, but what we can see is that there are several examples of clinical practice guidelines. This here is one from Nemours, where they use the pediatric appendicitis score to risk stratify their patients. Again, this one is another one, again, using the pediatric appendicitis score from St. Joseph in Tampa, and one from TCH, again, using the PAS score. In terms of using ultrasound templating, we also have content there that's available. And so what we found are that these are examples of, this actually here is an example from Children's Hospital of Atlanta, where they implemented a standardized template that not only included the visualization of the appendix itself and its measurements, but it also included the reporting of 8 secondary signs of appendicitis. And their results are actually also shared with us, and what they found was that this improved the accuracy of the ultrasound report, helped decrease CT utilization in patients with equivocal ultrasound studies, while still maintaining the same negative appendectomy rate. And then again, we have another example of another standardized ultrasound system that's been employed at Texas Children's. And their work was actually published in 2015 in Pediatric Radiology, where they also demonstrated that they had improved communication of appendicitis across all teams. And I'm going to turn it over to Dr. Wakeman, who will talk about MRIs.
There we go. All right, so Penn State Children's Hospital shared an MRI-centered project. This was led by Afif Kulayat. And they have relatively timely access to MRI at their institution, as alluded to previously by Dr. Ricca. Their clinical practice guideline actually uses MRI as their first diagnostic test for children who are able to lie still, so it's a little bit different. Impressively, they note the time from request to the scan start is 71 minutes. I wish I could get that. The scan takes 11 minutes, and so the time from request to interpretation is about 2 hours, which is pretty impressive. They also, I think, really importantly, share their MRI protocols. So these can be really helpful for a center who's looking to use MRI to diagnose appendicitis if you're trying to get that going. I would also like to add that the Pediatric Surgery Quality Collaborative, led by Kevin Lally and Terry Fisher at UT Houston, have done great work in this space. The PSQC is a collaborative representing about half of the children's hospitals within pediatric DSQIP at this point. The collaborative's first project, led by Mehul Raval, aimed to reduce the rate of CT scanning in the diagnosis of pediatric appendicitis, exactly what we're talking about right now. The group identified institutions within the collaborative that were both high and low outliers for CT utilization in the diagnosis and workup of possible pediatric appendicitis. They performed semi-structured interviews of these key stakeholders at each children's hospital. And then using qualitative research methods, they performed thematic review of the responses. They created a really impressive implementation guide, which actually has a lot of similar content to the APSO Quality and Safety Toolkit. So for more information for that, one should contact Terry Fisher. And actually a good recommendation is we're actually gonna see if we can get that put into the APSO Quality and Safety Toolkit. So overall, we hope that this work can be used to improve radiation stewardship in the workup of children with possible appendicitis, both at our institutions, but also in our referral networks in order to raise all boats. And we'd be happy to take any questions at this time. Thank you.
We should check with Marion. Do we have time for questions? Okay.
Yeah, Dave Scarta, University of Utah. So we've had kind of some versions of these diagnostic pathways in place for about a decade, and one of the things that we've uncovered is the potential risk for these pathways to create tunnel vision within the diagnostic vision of clinicians in the ER and among us as surgeons as well, where we potentially miss alternative diagnoses for right lower quadrant pain, Meckel's diverticulitis, Crohn's disease, urinary tract infections, ovarian torsions. Give me a sense maybe for what your thoughts are on how you mitigate that potential risk for tunnel vision as you implement these diagnostic pathways.
I'll try to handle that. I understand your question. What I would say is the evidence is, let's say, a little quiet on the issue of misdiagnosis alternative possibilities from appendicitis. To speak specifically to your question, our algorithm has within it the acknowledgement that alternative diagnoses should be considered several points along the pathway. So while not perfect, our hope is that it doesn't exacerbate the problem that you're alluding to.
Right. Yeah, and I think to echo on that, with the scoring systems at the beginning, again, I think, and that's an important part of this algorithm as well, is the clinical suspicion, right? That you still need to have that clinical index of suspicion. You need to look to make sure that you're doing a thorough job, and you're not just prompting to go to imaging without having that discussion. So, I think that's what you're getting at, is people are, tunnel vision just doing the imaging. So, you need to constantly refresh that, and at our institution with the MRI, we do that discussion. So.
It's Kathy Van Leeuwen from Phoenix. This is a great presentation, a lot of work. Why did you choose not to include non-operative appendicitis management?
We anticipated this question very clearly. In our algorithm, the upshot of someone with appendicitis is that they receive surgical care, however you define that.
Hi, Stephen Lee, Seattle Children's, great work, love it. My question is, a lot of times the ultrasound is done before the exam or labs are drawn. I know that's against the algorithm, but it's done, it's positive. So how would you include that in your algorithm? Would you consider labs necessary at that time for the workup?
Yeah, that's fair. I'll acknowledge that there's going to be some variability in and around this. I'm still kind of a classic Bayesian fella, so pretest probability should be built on something objective, and the scoring systems are kind of reliable, objective, have been validated like crazy. Our feeling is that even an ultrasound during or after is preferable to one prior to sort of that pretest probability establishment, which should be the score.
Yeah, it's just a lot of the ERs have that built in their triage where they see them by a physician up front and then they go straight to ultrasound. And therefore, the scoring systems usually include labs in it. So that kind of throws that off.
Well, and I think it's important, though, especially when you're looking at the radiation risk, which is, a premise of what we're talking about here, and we really need to focus on how do we get the appropriate imaging for the appropriate individual to minimize those risks along the way. And so I think to your point, Dr. Lee, that you need that information to make that important decision.
Do we have time for one more, Marion? Yes.
Last one.
Mike Livingston from McMaster. One thing that I joke with the residents is, the best test is the test of time. So for these patients with equivocal ultrasounds, if their pain goes away, that's enough. So just some opinions from the panel on that issue of time as an important factor, in terms of observation, in terms of, seeing how their symptoms evolve. What are your thoughts on that in terms of what the evidence would say, and what would you recommend? Thanks.
Yeah, the evidence is clear in the sense that patients with low probability appendicitis, it's extremely reasonable to provide a period of observation. And that can mean admission to some sort of clinical decision unit or sort of a short stay unit in the ED. It could be an overnight admission at your hospital. It could be even returning the next day for a reevaluation, depending on if someone's come from nearby or far away. High probability patients, it may be a little less reasonable to do that because you sort of want to get to your diagnosis a little quicker.
Time is a diagnostic ally.
Right.
And that is true for pediatric trauma patients as well, by the way.
Great. Okay, great.
I think that's our time, so thank you.